All right, welcome to the Explainer. Today, we're going to try and think like a neurologist. We're going to break down the single most important principle they use to solve medical mysteries. It's like a mental map that lets them pinpoint exactly where a problem is hiding in the nervous system. So let's just jump right in with a question that honestly gets to the very heart of the entire specialty. What is the single most important principle? It's not some rare disease or a high-tech scan. It's actually a way of thinking. And here it is, localization before etiological diagnosis. That's it. That's the golden rule. So before a neurologist even thinks about asking what is causing the problem, is it a stroke, a tumor, whatever, they first have to figure out where the problem is. Everything, and I mean everything, starts with where. Okay, so if you're going to figure out the where, you obviously need a map, right? And the nervous system, it's huge. But for our purposes, for localization, we can break it down into two main territories. This is really step one in our detective work. So here's how to think about it. You've got the central nervous system, the CNS, that's your brain and your spinal cord. That's headquarters, the command center, where all the big decisions are made. And then you have the peripheral nervous system, or PNS. Think of that as all the wiring, the communication network of nerves that carries messages from headquarters out to the rest of the body and then reports back. Okay, so within this map, we need to focus on two really critical motor pathways that carry instructions from movement. And understanding the difference between these two, well, that's how we start finding the clues we need to crack the case. So let's get into it. All right, first up, the upper motor neurons, or UMNs for short. The easiest way to think of these guys is as the managers. They're up in the C-suite, the brain's cortex, and they're the ones sending the high-level instructions down the chain of command, all the way to the spinal cord. And then you've got the lower motor neurons, the LMNs. If the UMNs are the managers, these are the workers right there on the factory floor. They get the final order from the managers right there in the spinal cord, and their job is simple: carry that final go signal directly to the muscle and make it move. Okay, so here's where it gets really interesting. When something goes wrong along either of these pathways, a lesion, as doctors call it, it leaves behind a very specific, very distinct set of clues. It's almost like a criminal leaving their calling card right at the scene of the crime. And this is basically the detective's cheat sheet. It lays out all the evidence for us. Just look at the difference. If you have an upper motor neuron lesion, so a problem up in the brain or spinal cord, you get things like increased muscle tone, which is called spasticity, and really exaggerated reflexes. That's hyperreflexia. But if you have a lower motor neuron lesion, a problem out in the nerves, you see the complete opposite. Muscle tone is decreased or flaccid, and reflexes are diminished or even gone, hyporeflexia. And look at the other clues. Really severe muscle wasting, atrophy, and those little muscle twitches you can sometimes see called fasciculations, those point straight to an LMN problem. And this right here, this is one of the most famous, most important clues in all of neurology. It's called the Babinski sign. So here's the deal. Normally, if you stroke the bottom of an adult's foot, their toes curl down. But if that big toe goes up instead, wow, that is a huge, powerful sign that points directly to a UMN lesion. It tells you the problem is in the central nervous system. So you might be wondering, wait a second, why does a problem with the managers up in the brain cause stiffness and crazy reflexes way down in the limbs? Well, it's because the UMNs don't just send go signals. They're also constantly sending these little, hey, calm down signals to keep the local reflexes in the spinal cord in check. So when you cut off that management oversight, the reflexes are basically left unsupervised. They just run wild and overreact to everything. And on the flip side, what about that severe muscle wasting you see with LMN lesions? That happens for a really direct reason. The lower motor neuron is the muscle's lifeline. It's not just carrying commands, it's also providing these essential nutrients that keep the muscle healthy. You cut that line and the muscle just withers away. It's that simple. Okay, but here's a curveball. What happens if the damage to the central nervous system is sudden and massive? Like in a major spinal cord injury. Well, the clues can actually be super misleading at first. It's like a classic red herring in our investigation. See, for a little while, right after a big injury like that, the entire system just goes into shock. They call it spinal shock. And during this time, the patient is actually flaccid with no reflexes at all, which, if you remember our cheat sheet, looks exactly like an LMN lesion.
It's only later, sometimes days or even weeks later, as those spinal circuits start to reorganize themselves without any input from the brain, that the true UMN signs, that spasticity and hyperreflexia, finally show up.
Okay, so let's put all these pieces together. Let's walk through the exact logical sequence a clinical detective would follow to solve the case using these principles. It's a 4-step process. Step 1, identify which system is involved. Is this a motor problem, a sensory problem, something else? Step 2, use the clues we just talked about, the tone, the reflexes, to figure out if the lesion is central, so UMN, or peripheral, LMN. Step 3, narrow it down even more to a really specific level. And then, and only then, once you have the where completely locked down, do you finally get to ask what is the cause. And here's the golden rule in action. Let's say a patient comes in with weakness. On the exam, you find they have exaggerated reflexes and a positive Babinski sign. Now, those 3 clues, they don't tell you if it's a stroke or a tumor. But what they do tell you with almost total certainty is exactly where to start looking for the culprit, somewhere along that upper motor neuron pathway, either in the brain or the spinal cord. So, you see, this whole principle of where before what, it's really the bedrock of clinical neurology. It's the mental tool that lets doctors take what looks like a confusing mess of symptoms and turn it into a solvable puzzle. And now that you know the secret, the next time you hear about a neurological symptom, I want you to try thinking like a detective. Before you jump to what could it be, stop and ask yourself, where could it be? I promise it'll completely change how you look at the problem. Thanks for joining us.